Hey everyone. So I feel like I know half of the room already, but I'll kind of reintroduce myself. So I work at Champaign County Healthcare Consumers, and we're a small nonprofit, staff of 5 people. But we essentially are the number one site for federally trained um, assisters. So that means that we can do the federal marketplace for private insurance. We can also do Medicaid. We help with Medicare. We have had some TRICARE, but those are kind of different outliers that we don't see too often. Um, so I started at Healthcare Consumers about 5 years ago, and I was brought in to help develop their social justice and criminal side, which was a collaboration between the Mental Health Board, Community Elements, which now became Rosecrans, and who took over the Prairie Center, to work on that team to help people reduce recidivism. So breaking that cycle of going back to jail, whether it's for lack of access to care, medication, whatever the reasoning was. So we could find them care, make sure they have a continuum of care, and then eventually lead to employment or some kind of benefit that they can self-sustain themselves for. So I'm going to start with like a brief overview of just the ACA in general, since that's kind of the major topic. Um, these are kind of the 4 points that the ACA was for. So it was to expand health insurance, which it did that in 2 ways. The Medicaid side, so you no longer had to have dependents. Anyone between the ages of 19 and 64 were eligible, regardless, as long as you met the income requirements. Improved coverage for those with health insurance. So the part that everyone always forgets is the first part of the ACA, which is the patient protection side, which means that it expanded it for everyone. So whether you had employer coverage or you were going to be looking on your own, it still got the same benefits. So all the employers go through this hunt for what plans to provide their employees. So if you're a small group plan or a large plan, you choose your top 3, and then you kind of offer that to your employee. So the patient protection part was across the board. So you'll see later on what those kind of standardized benefits were. There are 10 of them. The improving access to and quality of care. So this was, again, with the Medicaid expansion. So it's just more people can sign up. There's more access, better rates for reimbursement rates for hospitals and insurance companies, things like that. And then the last one was control rising healthcare costs. So everyone always knows every year insurance rates automatically go up. With the ACA, what it did is it created a regulating body. So insurance companies can't automatically say your insurance is going to go up 35%. With the ACA plans, they have to bid and say we're going to raise it, and they have to justify why they're going to do that. So they can't just kind of automatically put whatever price they want on there. So the marketplace would regulate that and say, well, why is the price going up? Where in this community, it's kind of staying within the same between competitors. So you couldn't have it like a insurance company running away with the prices. So it kind of kept that balance a little bit. So overall, usually before the ACA, plans were going about that 35% every year. With the ACA, it's been closer to 15. So they obviously still go up. You see that through your employer or through your individual plans. It's just at a slower rate. So this one here shows you the timeline for health insurance and how it came about. So it was signed in 2010, and then it rolled out gradually. So the first things were the dependent coverage. So anyone under the age of 26, you could stay on your parents until 26, and then you'd be aging out after that. No lifetime caps and no rescinding of coverage were big ones, because before the ACA, let's say you got diagnosed with something like cancer. Let's say you cost the insurance company $1 million. You hit that cap, and then they're done with you. They're just like, good luck finding other insurance. If you had a pre-existing condition, which that would be, that was the other big thing. So it provided a guarantee issue. So you couldn't be left out without anything. And and that was across the board for children and adults. The second part that came out was the cost sharing and like the increased payments, the delivery system that expanded Medicaid, and then it created that Navigator IPC group, which is where we came in. So it's the first round of folks that kind of were trained to help people navigate the system. The last part was the full Medicaid expansion. So that came under fire because it depended on the states to decide whether they wanted to expand Medicaid or not. So that kind of created some division between the states. There were court cases about that stuff. Some states expanded, some didn't. Some have since then expanded. We're still not at every state though, so there are still differences of coverage across state lines. Then we have the marketplace, and then the subsidies, the cost sharing reductions, and then the part that everyone hated was the individual mandate. So you were kind of being like forced to get an insurance plan, which it has a good reasoning behind it. The way that health insurance for the marketplace stood was in a tripod. So it's the mandate, the premiums and the cost sharing reduction, and then the expansion of Medicaid were like the three major things that came out. And so without one of those, it kind of falls out. And so that's kind of been the fight that we're fighting right now. I'll get to that at the end a little more with like current event stuff. Benefits and protections. So again, the 26-year-old thing. So you can keep it to your 26. Your parents can keep claiming you as a dependent. Even if you're not on their like taxes, you can still file your own, but you can have their plan until 26. Contraceptive coverage, testing, all these preventative benefits were included. And the protections, like I said, were across the board for either employer or individual plans. This medical loss ratio, what that means is of your premiums that you pay, before the insurance company can say, we're going to take half of that and it's going to go all for overhead. They can't do that anymore. So if you're selling a plan on the marketplace, it has to have an 80 to 85% premium, has to go to claims. So it stays in that service area as opposed to going to like the CEO, CFO, or to, just pay more salaries. It has to stay within that delivery system. So that was a good win in general, because that's always like a big fight with insurance companies, kind of keeping that money to themselves. This is, again, the three things that kind of came about it. So it created these income thresholds for what program you're eligible for. So the Medicaid is anyone under 138%. So that's roughly for 2019 about $17,000 a year. Anywhere between 139 and 250 is where you can go on the marketplace, get a subsidy, get a low cost deductible or out-of-pocket maximum, things like that. And then you can go up to 400, but then I think 400% is something like in the 50,000 range. So if you're below that, you can still get some assistance with like your premium, but like the sweet spot is that middle 35,000 to like 18,000, where like it's like the most vulnerable income-wise, I guess you could say. So you get the most bang for your buck for the plan, your deductible, your out-of-pockets, your co-pays are really low. So the marketplace specifically, skip this part. So the timeline, so open enrollment stuff. So everyone signs up between a very specific window. So November 1st to December 15th. The newest development is not on Sundays. So on Sundays, the site's closed for maintenance. So that shortens your 45-day window. For Medicaid, though, there's no open enrollment. It's open year-round. So if at any point you dip below that 17,000, which comes out to roughly about $1,300 a month in gross income, you can always like transition to Medicaid for short term. Like if you're a seasonal employee, during your summer, your hours drop, or winter, same thing. You can go back and forth. So So it kind of makes it so you can both save some money and not losing your coverage. And then you can always go back. So if your income changes, the main things that determine those kind of triggering factors are if you get married or divorce, if you have a child, or if you move to a new county. So those all trigger special enrollments. So that means that you can apply anytime within that year, within a 60-day window of that change happening. Otherwise, you are locked to those like November to December dates. So the special enrollments, like I said, those are the most common things. Aging out of the 26 bracket is another big one, especially here with college students losing their parents' dependent coverage. So who can shop on the marketplace? So if you're uninsured, if you are individual plan, and if you just bought it directly with the insurance company and you want to shop around, you can switch. There's like no penalty for that, as long as it's within that open enrollment window. People with COBRA, so that's another common one. You leave your job, it's a pretty stressful time. You don't want to spend your time shopping around for other insurance. People end up taking COBRA. It's very expensive though, so either you go without it or you get the COBRA and kind of suck up the price. You can sign up at any time within the COBRA, so that's kind of a lifeline that's out there. So, and then self-employment's a big one. So if you have no employees and you're just independent contractor, that's a very common one, especially here as well, with like a lot of techie people kind of doing independent jobs. Families, small businesses. The one exception to having employer coverage is if your employer is charging you more than 9% of the annual income towards your insurance. So if anyone has a question about that, because you have to do a lot of math for that one. Usually employers know that they can't charge you more than that, so they'll keep it right under that amount, which is, I mean, there's nothing illegal about that, but it puts it at a more expensive rate that you can probably get somewhere else. And then obviously you'd have to be a U.S. citizen, visa holder, or a permanent resident with a green card. Most visas are accepted, so we call them just like the alphabet, so A through Z of visa, so J1s, H1s, V1s, all those grad students, postdocs, like they all qualify. Who can't shop on the marketplace? So obviously if you have insurance, usually there's no real reason to have extra coverage, with some exceptions. But if you have Medicare, so Medicare would be if you're disabled and you get Social Security disability benefits for at least 24 months, usually the Medicare kicks in right after that. Or if you're over 65 and you're taking Social Security, then you can be on Medicare. If you're on Medicaid, which is because of the income, so under 138, you're on Medicaid. Above 139, then you're on the marketplace. And then individuals who are incarcerated or serving a sentence, there's a hold that gets put on your account. It doesn't hurt you. You can apply for hardship exemptions, things like that. And then undocumented individuals as well. So for the incarcerated one, that one's important because there are different rules for how long you serve a sentence. So I won't get into that detail, but usually more than 1 year sentence, you just kind of start from scratch. If it's less than that, then you usually can keep your insurance. You don't automatically lose it. So in the state of Illinois, if you get arrested, if it's your employer, they obviously can drop you. But if it's Medicaid, Medicaid can cruise for 1 year. You're incarcerated, so it's not benefiting you in any way, because while you're in jail, it's the county's responsibility to kind of take care of you. But there are some exceptions to that. Usually if you had an emergency and you had to spend an overnight at a hospital, then your Medicaid would kick in. But usually you just don't lose it. As long as it's been less than a year, you can keep it as long as you need to renew within the next cycle. So these are the 10 benefits that I was saying that are the key base standardized benefits for across the board. Ambulatory, emergency, hospitalization, maternity was a big one. I don't know if you guys ever saw or remember this, but when you signed up for insurance back in the day before the ACA, you'd have to fill out these forms. explain your whole pre-existing conditions. They could deny you for any reason. A lot of times maternity wasn't included in the package, and you wouldn't find out until you got pregnant, went to the hospital, and then you got a fat bill that came in the mail. The insurance company didn't have to disclose any of that stuff. It's all in the small print. You thought you were covered well enough because you had preventative coverage and your primary care and your specialty, but maternity was like its own individual thing. Another big one's the mental health and substance use disorder services. So that includes counseling, group counseling, individual, rehab, and habilitative services. And another extra part that kind of rolled out that wasn't getting a lot of news was that there's a parity law that rolled out that said that your mental and substance and behavioral health can't be charged more than your primary care. So most of these plans on the ACA, or all of them should actually, have whatever you pay for your primary care. If it's a $25 copay, your mental health has to be at the exact same rate. They can't charge you more for that. If it's a percentage that you pay, then it's the same percentage across the board for that service. Mental health was kind of funneling itself into like a specialty care, and it was kind of, the prices were going real high, and so that parity law kept it at par with your just basic services. So that was a kind of a good one, just because we've definitely got mental health, substance, and behavioral health issues at our jails, which is like a main resource, which is part of what I do, making sure they have that access to those services. Prescription drugs, you'd be surprised if you weren't taking anything and then you found out you had to take something and you went into the pharmacy and they'd say, nope, cash value. You're left on your own. Lab services, so blood work, diagnostics, x-rays, all that stuff. And then your WellCare preventative services. So across the board for all plans, you get that one free visit. And that one free visit is just your get set up, meet your doctor if you didn't have a doctor before. They can do all their preventative tests. And then from there, you can kind of do treatment plans if something came up. If nothing comes up, you have an annual one. You can just go. If you go once a year and that's it, maybe you go to convenient care or urgent care if you get sick. You pay that premium. You pay that that primary care fee. So all those like visits are just primary care. And then pediatric services surprisingly weren't a standard practice across the board. So surprisingly, dental and vision are also not considered essential, which is a big problem in a lot of places. What they did is they give you the option to buy a dental plan, but it's not in the package automatically. For kids, it is. So for anyone under the age of 18, it is considered essential. If you're 19 and older, it doesn't count. So you get the option to buy a dental plan. You're not obligated to. They just kind of put some out there for you to shop around for. The only way to get a dental through the marketplace is if you also get a health insurance plan, though. The good thing about dental is you can just buy dental insurance wherever, whenever. A lot of them will have a 6-month waiting period just because they don't want you to sign up and then automatically need a root canal. So they say, pay into the system for 6 months and then you can get whatever you need. Vision is another one. So for vision, most of the plans have a standard like $20, $25 copay for just the exam, but it doesn't cover glasses or contacts. So that's another place where it kind of falls short. This is the breakdown of the tiers. So in Champaign County, we don't have platinum, just because we're pretty small and we only have 2 insurance companies that provide here. So your catastrophic is specifically if you're 30 or younger. It's not offered to everyone. You'd have to be within that 139 to 250 percentile. Bronze is your 60%, and then down the line you go. In comparison to Medicaid, Medicaid's actuarial value is at like 96%. So when you're talking about everyone under 138 percentile, they're essentially in a platinum level plan. Same thing goes for kids. So if you have a mixed household let's say adults don't qualify for Medicaid, you're over that 139 percentile. One good thing in Illinois is that they've expanded the children's threshold, so you can make more money and you can have a split household where you might have employer or you might have an ACA plan, but your kids might qualify for either free Medicaid or they have higher tiers that cost like $15 per month, maybe $40 a month for the top tier one, and they still have that same 96 percentile of coverage. Medicaid does cover full dental, full vision, free exams every year, free glasses every 2 years. There are also other incentives. So, for example, I heard someone talking about the Carl Community Care Program. So if you have those financial assistance through the hospitals, a lot of time if you have Medicaid, you're automatically eligible for those programs at 100%. Not that you would probably need it because Medicaid would automatically cover most of that. But let's say medical devices, things like that, that could come out of those programs. Let's see. The difference between the plans is usually going to be in the bronze plan, they're the most cost effective, they're the cheapest plans, but they tend to be the higher deductible ones. So you're going to pay a lot less in your monthly premium, but when you use it, you are going to pay more out of pocket. So it might have a $6,000 deductible, and your primary and your specialty care and your lab work might not automatically be covered. So you might have to pay for that full doctor visit at like $200 or so, or the lab work or x-rays. The silver one will give you that kind of balance. So yeah, you'll pay a little more, but you'll have immediate access to those services. So it's all about kind of just doing the math. No one expects anything to happen throughout the year, but we do that cost analysis with you to say maybe you got something in your last year's test that might say you need more lab work done. You probably want a lower deductible plan just because you might need that benefit sooner than later. And then the gold one, not a lot of people choose those. They're just kind of there for that extra coverage. If you can afford it, you can go for it. Most people stick within that silver and bronze level. Especially younger people will stick within that bronze just because it's cheaper. You go to your doctor once a year and maybe a convenient care visit here and there. But it's always good to think about, like, know what to expect if something did happen, what would be your out-of-pocket cost. Catastrophic, I won't go over too much of that. I mean, it's like I said, you have to be under the age of 30 and receive the hardship exemption, which is, it can be a lot of different things. It could be a shutoff notice. It can be, if you're incarcerated, that could be an exemption as well. If you live abroad for 8 months or more of the year and you come back, you can get a short-term plan in those senses. For 2019, like I said, 2 companies, Health Alliance and Blue Cross. We obviously can't tell you which one to choose, but we'll go over those costs and what to expect with the networks and things like that. So the major issue here is if you go to Carl, you're going to probably run across some issues with Blue Cross. It just doesn't mesh as well. Obviously, Health Alliance is their own insurance. Like, we don't know who owns who, but they just kind of go back to back. So having the extra Carl Financial Assistance Program kicks into that Health Alliance plan, where in the Blue Cross one, it won't kick in. Like, if you have that cost, that financial assistance program through the hospital might not discount as much as it could with a Health Alliance plan.
Do you know, like, what the split is for population, their market share, essentially?
Health Alliance is usually, I'd say, at least like 75%. A lot of the Blue Cross ones are offered mostly by employers, like larger employers, if they're not local. So they end up going to Christie or OSF. I'd say most plans through the marketplace, most people choose Health Alliance. I mean, Carl, all their employees are Health Alliance. Health Alliance, all their employees are Health Alliance. So just by that volume of like being a large employer, other than the university that offers United, I think that's the other larger one. But yeah, most of it is going to be Health Alliance. The premium tax credit, if you're on the marketplace, it works in two different ways. You can either take it up front to get your lowest premium available, or if you can manage to pay a little more, you can get a lump sum at the end. You can also split it to whatever fits your budget. So that's kind of a good way. A lot of times, people that are self-employed would do that. So in the marketplace, you have to estimate your annual income for that year in November. So if it fluctuates, you can't really have a good guess if it's been different every tax year. So we try and get as close as possible. And then you can play with the tax a little bit to say, let's say you have a good quarter, we can elevate that amount. If you have a lower quarter, we can lower that amount. So you can change your income on the marketplace on a month-to-month, on a quarter-to-quarter, on a 6-month basis. As long as you end the year as close as possible, that's the part that really matters. So we do kind of maneuver around that to make the best affordable and like cost saving for everyone. Let's see. Income. So these are just kind of the standard income. So your wages, your net income from self-employment, unemployment income does count. Social Security does count, but only if it's disability or like railroad retirement. If it's supplemental security, that's another one that usually people get mixed up with. Supplemental security usually kicks in if you've not worked enough quarters for the IRS to give you your full benefit, because it means you haven't paid into it enough. So you'll get a standard, like it's like $770, $780, $80 that you get. Disability, you can get like $1,500, $2,000, $2,500, just depending on how much you've worked and paid into the system. With expanded Medicaid, again, it covers all the same essential benefits and more. So like I said, its actual value is really high. No cost for prescriptions, no cost for any appointment, unless it's like an emergency and it's coded. And like if you go to the ER, but it could have waited, they'll bill you for that. But even that's like a $5 copay. So across the board, you're just not really paying anything. These are the Medicaid plans in town. So there's 4 of them you can choose from. They're all accepted at least 2 of the 3 major facilities. So a lot of people tend to go that way just because you've got all 4 for the most part, with Francis Nelson included, and Rosecrans, which is the major #1 like behavioral, mental health, and substance provider in town. Now that they've kind of absorbed the Prairie Center and all of those treatment facilities, they're in contract with everyone. So I'm going to skip some of this stuff because I want to get to some of the more current event stuff going on. So these are just steps on like what you need to do your enrollment, like document-wise, and you guys know me now, so you can just reach out whenever. But I do want to talk about some current stuff. So the mandate, for example, that's one key thing that I'm going to give everyone a heads up on. When you file your taxes in 2020 for 2019, there's no more penalty that applies, so don't get tricked by any tax person trying to charge you for something that it's no longer in the law. But that comes with a catch. It's not technically out of the law. What they did is they just reduced the amount to 0. So it's still in the law, but your penalty is $0. So that brings us to the current event stuff, which is like the stuff that's happening in Congress with all these bills. And so right now there's a Texas case going on, Texas against the U.S. What they're doing is they are trying to fight that 0. Like we're already at 0, like we're fine at leaving it there. But what they're trying to do is take it just completely out of the law. And then I mentioned that tripod. So if it completely goes away, then your subsidies go away. Your pre-existing condition coverage goes away. Those caps go away. So it's just one of those things that doesn't make policy sense. It's like we're already that was the one part that everyone complained about. We reduced it to 0, so it doesn't apply anymore. Now they want to completely remove it and then just like tear every part little by little. So right now states are giving their input in support. Short-term plans are another thing that came about since that mandate got reduced. So that means insurance companies can now say, oh, you're not planning on getting pregnant anytime soon, so I'm going to take that out of the plan, save you $50 here, I'm going to save you 50 here for that, and then you get this like bare bones like insurance plan. And then let's say something happens that isn't included, you can't say add it back on there. You're stuck for the year. So that actually happened pretty recently to a client of ours. And it's a lot of paperwork that needs to be done. So it might seem very nice up front, just on its face value. In the long run, if you never know what's going to happen, so that ends up biting you at the end when the bill comes out. Threats to Medicaid, again, they're still trying to fight Medicaid, so adding work requirements. We already have work requirements. That's the thing that no one will say. Like, there are already work requirements. Other states expanding and things like that are an issue still. These are the states that are in support and in challenging this current court case. So we've got 17 states defending, 18 challenging, 2 that withdrew, 4 that are on the defense of the appeal, 2 that filed a friend of the court to keep the ACA, and then 8 that are just not interested in saying anything. So they have representatives going into this case to kind of prove standing of why we should keep the ACA. Which also brings me to the next thing, which is upcoming healthcare. What are we going to do about that? So we've got a lot of different bills being proposed. I mean, we all know there's like 20-something candidates running on just one side. So kind of how you talk about healthcare now, you hear about Medicare for all, Medicare for America, universal healthcare coverage, and single payer. They all mean different things. They use them interchangeably between their talks, but they're completely different. So I don't have it yet, but we're working on getting like a breakdown of what everything's going to mean. We already had one debate, and I think I tracked it just to see how many times it was being said, and no one ever really explained in detail. So I'll have more on that I can share later on. But because of the court case happening, that's kind of been our focus primarily. But yeah, like you hear all these terms being thrown out there and just kind of being familiar with what they actually mean. Everyone always talks about these like European countries with like universal coverage. It's like we don't pay anything, like they cover us at 100%. They don't have private companies, like it's all run in a single payer system. That's not true. I'd say 80% of these countries have private companies embedded within that system, but they have more practice in doing that. Like we're coming from it in a like full revamp of the system. It's not a zero-sum game. Like we can't just overnight change it. So it's got to be a gradual thing. So my take on it is everyone's focused on Medicare. If you know anything about Medicare, it's a whole different monster on its own. It's broken up into parts. There are individual players within those parts. And it's only it's 80% coverage. So you're left with 20%. I've heard 0 candidates talk about Medicaid using it as like the stepping stone. Like I said, 96 to 98 percentile actuarial value. It's not segmented the way Medicare is. For some reason, people just love Medicare. It's probably people that are not on Medicare that are supporting that. So it's just kind of getting these terms in line and kind of knowing what we're talking about when we are using them. And the last thing, how you can do or what you can do to help. So obviously I'm a resource. You can reach out with questions, or if you have friends of friends that need help. If you want to get involved and volunteer, we do have events where we could use people just bodies. I think I mentioned there's a fundraising event happening at the Iron Post in a few weeks. That's just like a fundraiser, just happy hour, jazz time, local musicians. And we do an annual presentation every year at the library on all of this stuff. So we update what the current plans are going to be, what those premium rates are going to be, any changes in the law. And so we'll have that coming up in October, right before that November deadline, because they usually wait till the last minute to give us the new rates. So some of the contact info for if you're curious about shopping, where you can go for that. And obviously we're a resource, so schedule just a sit down, just one-on-one appointment, just to kind of go over questions that you might have. And I think I'm done. Questions?
You said that before the ACA, costs were going up like 35% a year, and now they're only going up 15%. Like, there's really no other industry where costs go up 15% every year.
Yeah.
How is that? Why is that?
So a lot of it has to do with insecurity in the market. So what the way the marketplace works is they have to provide their bills and justify their hike. There's always going to be a hike. Like I think at the lowest rate, I think it went up 9% one year. Usually it's been around 15. To this day, most people, I'd say 60% of people are still covered by their employer. And those employer benefits go up like 40 to 50% a lot of times, which means that either the employer is eating a lot of that and making it so that the employee pays roughly about the same amount that they've been paying, or they've been able to negotiate like a lower rate with their brokers. So having that like high increase and then having the private sector on the marketplace not go up as much, it's a win, but it's still like they keep pushing that limit to kind of get to that same level to like 35 is like a standard raise.
Is that projected to slow down in the next decade, or are we going to see 15% in perpetuity until literally it eats up the entire economy?
If the law stays at where it's at without any of like the losses on courts and stuff like that, it is projected to go down. The main thing that drives it down was the mandate. So kind of losing that was really the strong arm of the law. And so the more people that signed up, the lower those rates could be. So losing that mandate to $0 kind of hurt it, because then insurance companies have to make up that some other way.
So healthy people aren't signing up.
Yeah, so healthy people aren't signing up, which makes that pool of people that aren't healthy more expensive. So that's kind of the tripod thing. Like you need that mandate to really push the market to balance out so that we can all have a lower rate increase, and have there be more money for everyone to use as well. So
are the actual costs going up from the hospitals? Like if you
So
look
yeah,
at
so-
Medicaid, are the bills for Medicaid going up?
no,
at
so
same
like the
rate?
services themselves are staying about the same. It's more of having more money in the pool to distribute for everyone else. So yeah, like I mean the pay rate for Medicaid has been constant. For Medicare, it's also been about the same. So those prices kind of stay pretty standard, but it's the private insurance, even though those hospital bills aren't necessarily going up in price. And there are people that are doing research and saying like, this would cost me this much here, and at this other hospital, why is it twice the amount? So that's kind of been a transparency thing that people are working on to say.
Who's leading the charge on that?
There's a few different ones. I think here in Illinois, it is Heartland Alliance in Chicago and the Shriver Center. So it's the National Poverty Center. And so they've got attorneys, they've got legal aides, they've got people on the ground like myself. So we're on the same like networks, and we share the same information. So all these studies that are being made between like, why does it cost this much in Chicago, this much in Champaign, and this much in Springfield, and then rural areas as well. So there are kind of groups working on that stuff, but it's fairly new. I mean, the ACA is only since 2010, 2014 since it all fully rolled out. So yeah, so it's kind of a developing thing. We have bills that are right now with like Carol Ammons and like State Senator Bennett, where they're like transparency bills to make sure to get some of that stuff more out in the public.
I guess the final part of this initial question on that constant increase is, you know, when I see like new buildings in town, half of them are built by Carl, like in the last 3 years. I'm like, yeah, no shit. Every year I can't buy the same insurance. They change the plan, and it's always more expensive and covers less because they're building half of this town.
Yeah, that whole Carl thing.
And it feels like nobody's chasing those dollars to figure out where that's coming from.
Yeah, I mean,
it's obvious where it's coming from. It's coming from everybody.
Yeah, everyone's pretty much funneling money into it. I think they're still in litigation over their community care program and their tax exemption.
It's not even the tax exemption. It's just the pure like brick and mortar of the structure, the square footage that Carl's built in this Champaign-Urbana, well, mostly Champaign, but in the last 3 years, it's got to be like triple what any industry here has done.
Yeah, I mean they're the #1 growing thing in the county, I think.
But when you can grow at 15% every year, no shit.
Yeah.
Of course you're the best, because there is no other industry that can grow at 15% every year.
Well, and they have the insurance side, so like,
Yes,
it's all like the same pool, so we don't.
They're vertically integrated in an industry that goes up 15% every year. It's only a matter of time until there's nothing else being done in this town except healthcare services.
Yeah, I mean, because they are the largest provider, they can kind of get away with it because they can still offer some cheaper plans than like Blue Cross can. It's like a 2-to-1 ratio from what Health Alliance offers to what Blue Cross offers. And Blue Cross tends to be a little more expensive because they have less plans. So there's like more people signing up on Health Alliance. Even if it's a cheaper plan, it's still more money going into that system.
I guess I'm just kind of wondering who's the advocate for the consumer? Because I don't feel like anybody's on our side.
I mean, we're on your side.
Well, right.
But if
I can afford a silver plan, you guys' main mission isn't just somebody who can afford a silver plan.
I mean, that's the most our bulk is silver and like Medicaid. It's usually one or the other. Like, there's not a lot of in between.
Who's advocating against the monopoly of hospitals and insurances? I guess that because.
Well, those have to be like statewide because every state has its own like system for their hospitals. There are people working on it, but it's all like backroom like stuff happening that like they're not ready to like.
No real advocate for transparency.
There's like trickling effects here and there where like certain small things like local, like I mean like we've got good representative here. Chicago's got some, Spring Hill has some, but then like the rural areas don't have anyone. And like even then like it's not enough to really push like a large enough thing to really create transparency across the board. Like we'll do little things here and there between coalitions and stuff like that, but as like a large picture, yeah, no, it's definitely like the scale, yeah. So we're fighting an uphill battle, but hopefully more people will kind of, or more organizations and just in general, hospital associations and kind of like having these like bridges between the consumer and the hospital higher ups, like getting that understanding. And so we like started a meeting with Carl where we go once a month and we let them know like we had these many cases where you guys messed up on either their application or their billing or double billed or their facility fees. So we kind of bring these complaints to them and say, these are all things that you should be more aware of. But that's still on the delivery side, not so much on the insurance premiums and like costs of services.
And that's not like a general overview, it's case by case.
It is, yes, it's case by case.
Is there any way that someone can audit a hospital's profit and loss statement each year and say, holy cow, like...
I mean,
they're private, right? So can you
most hospitals...
Right, but if we're mandated to buy into their system, shouldn't they have to tell us the profit and loss?
for health, for health?
I'm saying the Health Alliance, I want to see their P&L for 2018. How much money they make.
It might be, so I think most of the hospitals in Illinois are nonprofit by like their standing, not by definition, but just in a standing where like they.
I don't know. I just get suspicious when I see all this growth.
Yeah.
And the increase. Anyway, I don't want to monopolize the time.
That's a long talk, but yeah, there's a lot of stuff going on there.
Do you think like for hospitals to publicly display or to show their price online, for example, for transparency, do you think that will combat or have the result of like keeping the cost going up?
I mean, that's the effect we would want it to have. It just depends. I mean, for example, right now you've got the financial assistance program at Carl, and OSF has one as well. Carl's is like public, like they'll tell you flat, these are the income guidelines. OSF's is like a mystery. We don't know. It used to be really good with when Presence was running it. It was transparent. They had it on their website. It was like straight dollar figures.
Wait, you're talking about like how much income you make and then
yeah, so like there was more.
So
there's more transparency.
They will assist you.
So, I mean, that's just one fight right now that we're just like, can you just be transparent with that? But then, yeah, the services, like, what does it cost? If I could call Carl and say, I need this procedure done, how much are you going to charge me? This is my insurance. And if you could call OSF or Christie and say, they're charging me this, like, what can you do for me? That doesn't exist. Like, people are working on it, but it's not a thing.
They don't even know.
Yeah, no.
Yeah, there's
They don't even
no
know.
industry like us.
There's literally no other business like this, right?
Doctors' offices don't charge insurance companies the same amount either.
Right.
Yeah, so it could be
So-
your insurance company pays one thing, another person's pays another.
Why wasn't that part of the ACA to transparency?
So I mean, there were a lot of parts in the passing it that got like taken out in order to just pass it at where it needed to be. So I mean, like dental was taken away. The dental business runs even worse than health insurance. There is like no information for the consumer. It might say a $10 plan is going to cover your preventative. It might only cover cleaning, and it might not even cover a filling or an extraction. So it's just like no one will tell you. I've called a dozen dentist offices just to find out what one thing will cost, and they're just like, I can't say. Like, it depends on the labor that it's going to take for this procedure to be done. And it's like, what if I'm telling you it's like a straightforward anesthesia extraction done? It's like, well, I need to see, I need to take an x-ray, I need to do all these other things to give my estimate. So across the board, if in dental you can't do it, all the services that a hospital would provide, like for them to just have a list to say, but there are people trying to get some of that, but then it's getting everyone to play ball and across the board, like create a even playing field with private hospitals and nonprofits. And it's just, yeah, people have to report to stakeholders and to other people, and it's not a thing that they want to do, to just put that information out there.
What do you think about those doctors that are like playing outside the system? That kind of, I'll set up a thing and you pay me $50 per member per month or something. You can come see me anytime you want.
Not a fan.
Because it takes to like a free market level and like allows people to choose their own thing, or
not necessarily, but it's usually it ends up being kind of like for dental, there's like Medicaid mills. So like if you have, but in the same sense, like if you have like this free independent person who can do whatever they want, charge whatever they want, and like stay afloat, there's not, it's who is the accrediting and like regulating body usually will come into play for a lot of that stuff.
But hospitals are already charging whatever they
Right.
want, so
It's yeah. It's
just because they're bigger and they're incorporated, like
yeah.
for the most part, most of these guys are people that got disenchanted with working in the hospital system, open up their own thing. You go to their website, there's a price list, you come see me for a coffee, you come see me for this, you come see me for that, or hey, pay this subscription fee and you can come all you want every month.
So that happened here, where a lot of people weren't happy working at like Christie or Carl and tried to do independent, and they literally just ran them out of town. Like they just left. So we don't have a lot of that anymore, or if any. the hospital ran independent contractors out that wanted to open clinics on like their own, just because it's like you have to be able to do these like lab work, diagnostics things, and if you can't provide that service, they're not going to contract with you to do that. If all you can do is be a free clinic, that's as far as you're going to go. So like we have the Love Clinic who does that. We've got a few other like pop-ups, like I think the students have one, and it's like they can only do certain things, and then they have to refer you to one of the big players, and then now you're in their system. So it's kind of, primary care is like its own thing that you might be able to do that, but then other benefits or other services, they're going to be blacklisted from working with other providers. And we have that happen right now with OSF and Christie, because Christie can only do certain things. They're just a clinic, but then they have to contract with OSF to send lab work there. Francis Nelson is our qualified health center in town. They have to work with Carl in order to send lab work there, or some more intensive procedures there. Same thing if you have like a high-risk pregnancy, they can't take you. You have to be sent to the hospital. So a lot of that stuff is just, they're going to close the door on you if you're not playing ball with them. So, yeah.
It's just, it seems like a lot of like, like old, 1800s, the railroad or the mining company owns the whole town and they issue their own dollars, and like, like you just can't get outside of their system. Like you literally have to go to Chicago or Springfield or Mattoon or, somewhere away to get out of the kind of Health Alliance Carl system.
Yeah, pretty much. I mean, anywhere in the central Illinois, you're going to probably run across Health Alliance. You get more diversity in Chicago area, but even like further down south, like it's still a 2 to 3 insurance company like system.
What's the percentage of people you meet that are like enraged about this? I mean, I grew up somewhere else.
I mean,
This is not how it has to be, and this is literally the worst thing about this country.
Yeah, I mean, it's essentially everyone. There are very few people. I mean, people will leave content, but it's like, well, like I thought it was gonna be more expensive. I'm glad it's not that bad. It's mostly I'm glad it's not that bad, but like I'm really not happy about it. So it's and that's why I was saying like it's with like all these new stuff coming up with new policies, like a lot of people are so tired of it that they're willing to say, let's just wipe it all out and like start clean. And it's but like I said, it's not a zero-sum game. Like if you do that, you're gonna leave a lot of people behind that are gonna, without like hiding it, like they're just gonna die because they're not gonna have anything. So it's like people are missing that human factor when they're talking about these things sometimes. So it's like no matter how enraged you are, like it's got to be a building block. It can't be like turn a switch and just automatically we're gonna all revolt and like start a whole new system. No matter how much we'd want to do that, it's just not gonna be. It's not feasible. It's not humane. It's not gonna help us in the long run. So it's like little battles here and there, just picking at it as we can.
If you had your choice, would you prefer like completely no insurance, free market system, everybody pays cash and the prices whittle themselves down over the course of time, or everybody just pays in via their taxes and then everything's free for everybody?
The problem would be like who's doing the delivery, the service deliveries. So you say like free market thing, like there are always most likely going to be private insurances embedded within those systems. I mean, that's how it is in like a lot of the single payer countries and like universal coverage. Like they still have them there. They're just regulated so much better than they are here. Like here, they just have a free reign over everything. I mean, pharmaceuticals here in the U.S. are like the worst, along with hospitals and all those things. So it's just it's a complicated system of who's paying, how much do we need to pay into to actually make it affordable for everyone. The system, like the bare bones of the structure, the delivery systems, what rates are you paying for certain things? Like the one Medicaid and Medicare do have like flat rate fees that they reimburse. Medicare's probably, I think, a little better just because it's a federal thing where everyone is across the board on the same playing field. But Medicaid, like state by state, some states are way better than other states. So it's a matter of like which system are we going to adopt and which one are we going to actually use to build to get to that point where people can be happy with what their fees are and like there's transparency and the system is result based and not like just issuing like all these tests. Like that's been an issue with the ACA, creating accountability for the physician so they can't just like send you to do all these lab work because they know that your insurance is going to pay for it. It's like now you have to show end results. You have to show that whatever you're diagnosing is actually correct and you're setting up a treatment plan. So they can't just bill, and then hopefully you get better. Hopefully, something happens. But so there are like little changes happening like that, but it's on a small scale. So, yeah.
What's your ideal solution?
I don't think I'm allowed to. Yeah.
No, because you keep answering, like everyone is angry about this,
Yeah.
but none of the solutions that are out there work in and of themselves because someone's going to get lost along the way. So
Yeah.
what do you propose as those small steps, or what is the direction that we should be looking to make changes?
So, I mean, my first step would be by standard, just defend the ACA of where it stands. And because the insecurity within insurance companies of what they are wanting to raise their rates to, you have to do that the year before. So if you don't know what your market share is going to be, you don't know how many enrollees you're going to have, you're going to raise that to fill gaps where there's going to be gaps. So if we could keep the ACA and somehow create like some stability between like the number of enrollees and who's paying in, the pools of like sick to healthy, and then it could go so many ways just because there's people fighting it across the board, like at every single step. So like you win one thing and then they'll find something else to try and like tear it down with. With the mandate, like we are already at zero. Like, aren't you happy that like you don't have to pay a mandate now? But then it's like you take that part away and then there go your pre-existing conditions. There go your like subsidies. And then we're really not going to be happy because then instead of that 15%, they're going to be up at 50% raised every year because the insurance company have to make up that difference somehow.
Well, they don't have to.
Well, they don't have to,
Because
but
we don't get to see the
but they
books.
will
We don't
justify it.
actually know if they
Yeah.
have to or
Is
not.
there anyone proposing that they're more regulated so that they can't make those changes instead
So
of putting
that-
it on the consumers?
So that would be like a next ACA step. So if we win whatever we have going on right now, and then it would be lower the rates or expand in whatever services we can, either lower the premiums, lower the deductibles or out-of-pocket costs. But that would be like, we'd have to be not fighting on one end to actually do, because that's the thing, like we're always playing defense. Like we can't go offense because we're always having something to fight for. So that's been the last like 6 years essentially.
Last question. Anyone else?
What do you think? I grew up in the German system, and we have private hospitals, we have not-for-profit / government insurances, hospitals, all that. The main difference I see is that the government regulates the price. Every year they bring out a catalog of all services that any hospital, any doctor provides, and says this is how much you can charge. I think that would be a great solution without having to, dismantle companies.
Yeah, and so that's like one of the things, like creating that transparency and having everyone have the same playing field of like the system, so you know what you're getting ahead of time. It's happening like in very spotted areas, usually like the stronger states that have the funding and have like organizations and policy and law and like attorneys and being able to regulate pharmaceutical and the delivery system within the hospitals. But that's like one city or one state. So yeah, having it be across the board, I don't know what that would take. Like if it needed to be like a another like federal law that kicked in to create transparency, but we can't even do it on the state level. So, yeah.